Rob, do we need to do anything to get the broadcast started or the recording started or whatever we need to do before we kick it off?
Nope, it's starting.
Okay. So I think then we should get started, and I'm going to take myself off. Just want to thank everyone for being on this webinar. We have a really great agenda coming up, talking about nursing issues in the COVID pandemic, and we'll start with an introduction from Mary Turner.
Good morning, nurses, and welcome to the second episode of Nursing in a Pandemic, Part 2, presented by, I can't brag enough about our staff, and especially these group of nurses that are going to be leading this. Oh, Jerry, you're not a nurse, but you're okay too. Right?
Thank you.
But anyway, I was thinking today, you know, with all of the worries that we have and all the anxiety that we have, with PPE and with nurses' jobs getting cut and things like that. The one silver lining is that for our union, we have kind of been forced into using social media to the max. And I think that that is a good thing, because we have how many people on this webinar right now today? Over 200. And we've been having such good participation in all of our meetings because people can just get on their little computer and join in versus having to come down to St. Paul. And that's a good thing that I hope, and we've been able to tie everybody in all the way from Wisconsin to Iowa to North Dakota, Minnesota, all together. And that's a good thing. And that is something that I hope we will continue. And so that's the silver lining for the day, guys. And wishing you all well. I go back to work tonight too, and living the dream. That's what we're doing. But these ladies are gonna show us how to try to do it as safe as possible, right, guys? Yep. All right, take it away. Thank you.
So we have a packed agenda today. I'm really excited about this presentation. We have an all-star lineup that's going to be presenting today. So we're going to start with a couple of the MNA staff members, and they're going to talk about crisis care models and some practice issues, including delegation concerns. And then we have really special guest speakers that are going to be talking with you guys. So Eileen Weber and Brittany Livakari, I hope I pronounced that right. When it's more than a syllable, I get really confused. And Sarah Simons are going to talk. We're going to hold off on answering any questions that you might have until the end of the presentation. So if you participated last time, we're going to use the same process. Don't use the raising hand signal thing that's in your toolbox, but go ahead and type out any questions that you might have in the chat box, and we'll try to get to some of those at the end of the presentation. Also, for the first time with one of our presentations, we've uploaded a handout. So throughout the presentation, you're going to hear some different references being cited, different links and different resources that you can use. So if you look in your little toolbox there, you'll see a section called handouts. If you click on that, it should download to your computer, and that'll give you some of the additional resources that we're going to be presenting on. So we're going to go ahead and move on to the next slide, please. It's a little hokey picture there, but we did, before we got started, we did want to take, oh, I'm getting stuck with dog hair. We did want to take a minute and have a moment of silence in recognition of our brothers and sisters in nursing that we've lost during this pandemic, and also in recognition of the Hennepin County paramedic that we lost this week. So I'm just going to ask everyone to take a couple moments and just be silent in reflection of those people we've lost. Thank you. Rob, if you can turn the slide now. So our first presenter is going to be Carrie Mortrude. Go ahead, Carrie.
Good morning, everybody, and thanks again for joining us. I think I can speak for all of us in our department to do a lot of education with you all, is that we'd much rather be in a big room with you or at your facility doing these kinds of educations, but we're going to do the best that we can using all of our virtual tools that we're all getting better at day by day. Robert, if you could advance to the next slide, please. So I'm going to talk a lot about the staffing models that you may have already seen or are going to start seeing as we move toward a potential uptick in patients and or a surge. And I'm just going to give a little bit of background for a minute to explain where some of this came from. And by no means am I an expert at this, and some of it I was actually reading this morning and understanding more as I was reading. So I'm going to give you just a little bit of history on where they came from so we understand why we're in this, and then we'll talk about some of the staffing proposals that have been put out. So some of you may know about the crisis standard of care framework that a lot of our states are operating with. And I'm just going to, for ease, use Minnesota and the Minnesota Department of Health, but these actually are endorsed and supported on a national level. So the United States Health and Human Services commissions support these as well. So the outline, the framework is supposed to outline the Department of Health's response during a crisis standard of care situation, and then provide planning guidance to healthcare facilities, public health, organizations that deliver healthcare, including EMT, emergency services, ambulances, etc., and assist them in how to move through successfully the transition from different stages of a crisis. So I'll talk a little bit more about those stages in a few slides, but just to give you a little bit of background, they are the conventional stage, which is business as usual. We have all the same staff, all the same patient care areas open, elective surgeries, and supplies. The next stage is contingency, which means that we have to start thinking about doing things differently. It may be talking about different types of PPE or conserving it, talking about where we would open up other beds if we needed more ICU beds, etc. And then the final stage is the crisis stage. So that's where we don't have a choice. There are no supplies, there are no staff. We have to figure something else out. So that's just the basis of the framework and how it moves from stage to stage. Like I said, the actual framework itself has 6 different categories that deal with ethics and procedures, etc. I'm going to talk about staffing, and then as Christina had mentioned, Eileen is going to talk a little bit about ethics in a little while. So there are multiple standards of care, and as I was doing some research, I realized that there's crisis care, crisis standard of care, and scope of practice, and that maybe it would be helpful to understand the difference between those. So scope of practice is the professional activities in nursing that are defined under state law. But standard of care provides the definition or provision of services in a manner consistent with care that any other professional with the same training would be expected to deliver to that same patient. So again, the scope is what is identified in statute, and the standard of care is how we expect that the same care be delivered to a specific type of patient, i.e. it would be a standard of care for a cardiac telemetry nurse to watch for atrial fibrillation after any kind of heart procedure. So either like a pizza or angioplasty, those kinds of things, when the electricity of the heart is dealt with, then it's very common to see that as a outcome. And so the standard would be that you would be expected to look for those. Crisis care is like when a disaster happens and you need to act immediately. So there's no time for planning ahead. There should be a plan in place, but there's no time like we have right now where we see different systems picking different processes to institute. So for example, the 35 bridge collapsing was a crisis that we all needed to react to in the moment. It wasn't that HCMC had weeks and weeks to plan on how they would move these patients to this department and or reopen, these areas to take care of patients. So that's just a little background. And like I said, this is supported by the National Health and Human Services Division. So it does go across the country. So if you want, Rob, if you want to move to the next slide. So again, this is a copy of one of the pages. There are a lot of pages in this document, and probably a couple pages before this, there's some definitions, and I'm going to talk about those, but then I'm going to specifically draw your attention to this chart. And I totally realize it's super tiny and you probably can't read it, but as Christina noted, we'll make sure that we provide links that you can go in and look at this more in depth, but I just wanted to give a bit of an overview. So in the actual summary card that is a couple pages before this, it talks about the strategies to be employed and talks about preparing, substituting, adapting, conserve, reuse, reallocate. And so on the chart in front of you, you can see that it talks about preparing, conserving, substituting, adapting, conserve, and then adapting again. And like I said, the definitions of the stages we move through that you can see, the conventional is green, contingency is yellow, and crisis is kind of that peach color. So the capacity definitions, just to give you the full definition, conventional capacity is the spaces, staff, and supplies used are consistent with daily practice within the institution. So these practices are used during their setup and business as usual. Conventional is business as usual. Then the contingency capacity talks about the space, staff, and supplies used are not consistent with daily practice, but provide care to a standard that's functionally equivalent to usual patient care and practices. These spaces and practices may be used temporarily during a mass casualty incident or on a more substantial basis during a disaster. And then finally, like I said, the peach color is crisis, and that is adaptive space, staff, and supplies are not consistent with usual standards of care, but provide sufficient care in the setting of a catastrophic disaster. And that could be one instance, or like we're experiencing right now, the pandemic. So on the page that you're looking at right now, I just want to draw your attention again to the green, yellow, and peach colors. And a question I would have for some of you is to try to find out if your employer is letting you know when you move from stage to stage. And if not, why not? And then how can you find that out? Just so you sort of know what to expect. In the top paragraph, the first bullet says, assure that the facility has process and supporting policies for disaster, credentialing, privileging, etc., supervision, required clinical scope of practice, mentoring, and orientation. Now, we've heard that they're not involving any of you in any of this planning, which of course is not the correct way to go about it. We believe and we know that you guys are the experts in how best to deliver patient care, so you should have and should be involved in all of this kind of planning. If you look to the next box where it says focus staff time on core clinical duties, one of the bullet points that we're concerned with, and we know that you're dealing with, is it says cohort patients to conserve PPE and reduce staff PPE donning and doffing time and frequencies. So we've said from the beginning that none of you should have mixed patient assignments. There should be cohorted COVID positive patients that are in one assignment and rule outs in another, and for sure not mixing those that are not in for rule out and not positive. And then the fact about the PPE, we could have an entire webinar about that, but I just wanted you to be aware that this is what your employers are likely implementing. They're going by this process, and we're not endorsing it, but we're just pointing out where possibly some of these decisions are being made and where you should push back to protect yourself, which then protects your patients. If you look down to the fourth box where it says focus staff expertise on core clinical needs, you may notice that the first bullet talks about personnel with specific critical skills like ventilators, burn management, should concentrate on those skills. So when I get to the next slide that's going to talk about the pyramids and the staffing, you're going to see a section that talks about unit support staff. And when you're in the critical care areas, they have brought in APRNs and are asking that they be part of the team to manage ventilator care in this kind of crisis that we're in right now. So Robert, if you want to go to the next slide. So this model is from the Society of Critical Care Medicine, and thankfully, so far, we have not seen this actually presented as the model that's going to be used. It has been sent out as a background piece on this is what we're going to look at in order to create our model of care. But as you can see, this is one that was built for pandemics and crises situations. So at the top, there's an intensive care trained MD. And then for every 24 patients, there's a pyramid above it. And as you can see, what it would boil down to is that there would be one ICU nurse for 6 patients working with 3 non-ICU nurses. So those 3 non-ICU nurses would typically probably have 2 patients, and then the ICU nurse is responsible for the ICU cares of 6 of those patients. So again, this is just a generic model that we were anticipating to be brought here and used. Luckily, so far, it looks like some of the employers that have moved forward with their staffing plans are actually being a bit more generous. So with that, Robert, if you want to go to the next slide. Here's an example of the ALINA model, and this talks about the critical care plus model and the critical care model. So compared to the pyramid that we just looked at, it seems that there's 7 different sections on this one, and really there's just 6, because that bottom yellow one just talks about the nursing care team and how many patients they're responsible for. So the one section that is added to this is that the critical care charge nurse. As you can see in the pinkish purple box, it talks about what the actual ratio would be. So in the critical care plus, so the most critical patients we anticipate having, the ratio would be 1.33, so 1 ICU nurse to 1 to 2 patients. And you can see on the left-hand side that unit support in the critical care plus model and the critical care model, it includes unit support that would include staff used for positioning and mobility, hygiene, vent management. So this is where you would see the APRNs involved, emergency line intubation, perfusionists, et cetera, and then an RN extender. And I know Jackie's going to talk a little bit more about that. So I just want to give you a picture of what this example that ALINA has presented. And I'm sure all of you know, but ECMO is the treatment used to pump and circulate blood through an artificial lung and back. It's usually only used for very ill babies, but we are actually seeing a few stories come out that adults are being put on ECMO therapy and then having good results. So, and then ARDS is acute respiratory distress syndrome, which you all know is what we originally thought and are treating patients for COVID when they get to that point. And then CCRT should be actually CRRT, which is continuous renal replacement therapy, and to pull the blood out and eliminate all the waste in it and then recycle it and put it back in. So that critical care plus unit is where those types of patients would be. Okay, Robert, if you want to go to the next slide, I am almost done and we'll hand it off to Jackie. So this one is the MedSurg Plus and MedSurg model. So the difference here you can see in the pink and purple is that the staff would have 4 to 7 patients in MedSurg Plus and could have 5 to 7 on the or 5 to 8 in the MedSurg. At the very bottom of this pyramid, the yellow section shows that the nursing care team on days for the MedSurg Plus would have potentially 4 to 5 patients and 6 to 7 on nights, and then on the MedSurg unit, 5 to 6 on days and evenings, and possibly 7 to 8 on nights. And here the difference with the unit support is the positioning and mobility, hygiene, and nurse extenders. It doesn't include the perfusionist and the APRNs maybe running the vents, etc. So those are the differences with that. And with that, I believe we have one more model to look at. Yep, there it is. So this one we recently received from North. So if you look at the left, the circle there, it just talks about primary current nursing care, that you have the patient at the center, and then there's, you know, a nurse for 8 hours, a nurse for 8 hours, and a nurse for 8 hours, or you could have obviously 2 12-hour nurses. But if you look at surge team nursing that they're talking about, there would be a charge nurse with 2 ICU RNs, and then working with them could be multiple med-surg nurses and an NA for a group of patients. And we haven't exactly got those numbers on what those ratios would be. I know that the North Steward group is working with the labor rep and Mary, obviously, to come to some sort of understanding on what the expectations are with that. But those are just a couple of the staffing models that we wanted to make you aware of and remind you that you should always make sure that you protect yourself and your license, because that actually protects the patients, and also realize that things are going to look a little different. And so while we realize that's very unnerving and unsettling, especially at this kind of critical time, but we're going to do the best we can to help walk you through this, answer your questions, and hold those accountable that should be giving us answers to give us answers. So with that, I'm going to pass it off to Jackie. Oh, sorry. The last thing I wanted to end with is skills versus seniority. While we 100% need to maintain and defend every contractual right you have, you all know, and we need to make sure that the employer considers as well, that sometimes seniority and skill have to be talked about, and it may be that we need someone with a little bit more skills, and they may be farther up the line for seniority, and so that could cause questions and maybe some issues, but we do need to consider that. I know that if there was an ICU nurse on a unit and being assigned given 3 med-surg nurses to work with, but they're all just out of nursing school a couple months because they're lowest on the seniority list, that could cause some concern and issues for that ICU nurse that's responsible for more patients than what they would normally get. So that's the last piece I wanted to present, and I will give it to Jackie now. Thanks.
Hi, everybody. For those of you who I have not had an opportunity to meet in a prior education or at your own hospital for any special meetings, I am a registered nurse, and I've been a nurse for over 20 years. And my area of practice was primarily emergency departments in all different levels. And I'm also an attorney. I've been with MNA for about 2 years, and with MNA, I'm your nursing practice and regulatory affairs specialist. And so my topic is delegation. The reason why this topic came up is because as we're looking at these new staffing models in preparation for COVID teams, we're seeing a new term called a nurse extender or a nurse helper. And as you saw in Carrie's slide, that there is a physician at the top and then an ICU nurse on the second tier, and then nurses on that team that work having their own patients. And a lot of these staffing models show that the ICU nurse delegates to the nurses on her team who have their own patients. And so a lot of questions have come up on what does delegation look like in that staffing model, because in our history, delegation is generally to a nursing assistant or certified nursing aides. And so I looked at other states and how other states were defining delegation in COVID teams. And what they have done is just look back at their own Nurse Practice Act to see how is delegation defined under the Nurse Practice Act, and then emphasizing the importance of being knowledgeable on that definition so that when a task is delegated, that you understand scope of practice and what that looks like. So in Minnesota, under Minnesota's Nurse Practice Act, the definition of delegation is the, quote, transfer of authority to another nurse or competent unlicensed assistive person to perform a specific nursing task or activity in a specific situation. And it gets a little confusing because in these staffing models, that's not what we're seeing when the med-surg nurses working underneath an ICU nurse. As far as the tiers go, they have their own patients. So what is their scope of practice? If the ICU nurse is delegating to the med-surg nurses, and our definition here in Minnesota is delegation of a specific nursing task or an activity in a specific situation, what does that look like when a nurse has her own patient? She would be expected to practice to the, within the scope of her nursing practice. So how is an ICU nurse delegating to another nurse? So it gets a little more confusing because in these staffing models is a newer term for us, which is a nurse extender. So there's the ICU nurse, the med-surg nurses, which are generally called nurse extenders. And as nurses are looking to deploy to other areas, you may have it may have been discussed if you're going to be deployed that you'll be a nurse extender on a team. Well, the definition of a nurse extender from the National Institutes of Health is that a nurse extender is a healthcare professional such as a certified nursing assistant who assist registered and licensed practical nurses in patient care in the hospital or nursing home setting. So a nurse extender is, according to the National Institutes of Health, an assistant, a nursing assistant. And under our Minnesota Nurse Practice Act, the definition of delegation is a specific task in a specific situation. And as we know, a nurse, before a nurse can delegate, needs to know what the competency and skills of the nurse assistant that you're delegating the task to. And we know that the nurse is responsible for checking on that delegated task to make sure that it was done as it should have been, and didn't injure the patient in any way. However, I've seen some other models where the RN extender is defined a little differently in these staffing models. For example, from Health East, an RN extender assists with the management of the patient assignment, partners with the primary RN, and may delegate to support staff. The skills that a nurse extender is expected to have and use are the reassessment of adult patients, reassessment of pediatric patients, the management of acute symptoms, medication administration, pain management, vascular access and phlebotomy, discharge documentation, specimen collection, procedures, procedural sedation. And these are not tasks that a nursing aide would do. And so these are within the skills and scope of our RN practice that require, many of them, nursing skills and judgment, such as procedural sedation. And so there's some overlap here, or there's use of these terms. I'm not sure if, how they're applying the RN extender to these care models when the definition is of it's different than what we're seeing in the care models. And so I guess, I'd be interested in hearing from you and what your experience is as an RN extender. What I've heard from other nurses is that they have been given the role of nurse extender and then been deployed to another unit and actually been given assignment as if they were floating to that other unit. So we do have some concerns because much of it has to do with training and nurses being deployed to areas or units where they may not feel or have not actually had adequate training. And so it's different. The perception is different if a nurse believes that she's going to another unit as an extender or as a helper to be on that unit, which helper is another term that we see being used with the extender, and a helper is more of a runner, and nurses are being deployed to units to be an extender or helper and then get there and actually have their own assignment, which is what the staffing model shows, that each nurse would have her own patient. So it's confusing. I don't mean to confuse you any more than this issue already is. I just wanted to, discuss it in terms that we know and we recognize, and that what is important is that no matter what role that your hospital is assigning you to, you are still a registered nurse and are still practicing within the scope of your practice under your Nurse Practice Act. If you are given an assignment on a unit that you're not trained or knowledgeable to provide safe care to that patient, the Nurse Practice Act will still support you in refusing that assignment. And just to clarify, we don't mean when we say refusing the assignment or teaching that, it's because you're in a situation or position where you know that you are not going to provide safe care. If you've never worked in an ICU and you're assigned to an ICU as a nurse extender or helper, and now you have your own ICU patient and the skills are beyond what your training is and you can't provide care safely, then the Nurse Practice Act will support you in refusing that assignment. So there may be a lot of questions about this. I'm happy to take any questions you may have, and we can sort it out and look at your own specific situation so that you're practicing safely. Robert, if you could just advance the slide, please. So just some terms that you're going to see in your assignments as you get ready to deploy to certain teams. And, today we just really want to talk about delegation and what that looks like on these new staffing models and what your scope of practice is expected to be. And if you just bring it back to, you are a registered nurse you're responsible for the care that you provide to the patient, and that you have the support of the Nurse Practice Act to refuse a patient assignment that you cannot provide safe care to, you should be pretty good. If you could advance the slide, Robert, please. So that's all that I had to discuss about delegation, and here are some references for you, and we'll be happy to provide these to you if you email us or you want a copy of these. So best to you all. We're thinking of you and working with you all every day, and please feel free to reach out to me at any time. And so, Christina, we can move on to our next presenter.
Thank you, Jackie. We're going to hear next from Eileen Weber. Eileen is a clinical associate professor at the University of Minnesota School of Nursing. She is an affiliate faculty at the University of Minnesota Center for Bioethics, and she is a former MNA vice president. Go ahead, Eileen.
Thank you, Christina, and thanks to all of you for inviting me. I'm proud of decades of membership in MNA and think there's no other organization in the region that represents the voice of direct care, hands-on nursing, and the people those hands touch, as well as MNA does. I'm sorry I can't somehow connect the camera. I don't know if it had to do with the link or whatever, but hopefully you can hear me okay. And just imagine what a 63-year-old silver-haired person who sits on her butt all the time looks like. Okay, so the reason I was invited, I think, is to talk about some of the ethical issues and ethical work that's being done related to COVID. And so there are, I think, a couple slides that I submitted that hopefully you have. The one that says ethics, code, and guidance. Yeah. So the Code of Ethics for nurses really points out a few very important things that are non-negotiable. And one of those is, yes, we have a duty to care for patients and to respect the dignity and worth of every patient that we take care of, but that we also, it's very clear in the code that we also owe that duty to ourselves. Self-sacrifice is not a sustainable strategy. So it's very important to know that we owe a duty to ourselves as much as we have a duty to our patients. And we also, and employers also have very strong duties that, in my opinion, have not been very well carried out by the healthcare system as a whole, and employers to prepare for this pandemic, which was definitely foreseeable. And even as it was becoming more imminent, there was not sufficient preparation for that. And I mention that because it leads to some of the justice issues that go to rationing decisions that I'm going to bring up here. And also pulling from the Code of Ethics, we also have a duty to advocate. You all know that already. From the bedside to the White House, we have a duty to advocate, and that we should not experience any retaliation for that advocacy. I spoke with a physician who's practicing out in New York City just like a week and a half ago, who spoke admiring, like in awe of the nurses who were protesting in New York City wearing the garbage bags, saying this is the kind of PPE they were expected. And it was a dramatic statement, but this physician told me that the physicians all got memos from their employers saying, don't you dare think of doing anything like this. You are not to be speaking out like this during this crisis. So we should not experience any retaliation for speaking up about what's going on in healthcare settings. But I think the main reason that you invited me to speak has to do with some of the groups that I'm involved in right now that are discussing, Carrie mentioned crisis standards of care. What do we do if we really get to statewide declared crisis standards of care, meaning that we don't have enough of what we need for people who are in life or death situations? So what happens if we don't have enough ventilators, for example? What happens if, because of the lack of personal protective equipment, CPR can't be performed even when it's really medically appropriate to do so? And by saying medically appropriate to do so, I'm talking about when CPR would be more effective than in times when it's done, when we know that it'll be futile. What about when it's appropriate, but we're not going to do it because we don't have enough PPE, or the limits of PPE make the timing of the code decrease its effectiveness? So some of these frameworks are being discussed right now. One of them is a statewide group called the Minnesota COVID Ethics Collaborative, and it's roughly about 50 medical leaders and ethical leaders from around the state, people from government, from healthcare systems, from the university, and we're discussing ethical frameworks for what to do under crisis standards of care when rationing has to take place. And some of this is based on a project that was published and is on the Minnesota Department of Health website. It's called the Minnesota Pandemic Ethics Project. So kind of in the section that from where Carrie Mortrude pulled the information about crisis care, there you can find the ethical resources, the ethics resources, and the Pandemic Ethics Project is there. The Minnesota Pandemic Ethics Project listened to people all over the state. It was kind of in response to the H1N1 flu pandemic that we had, which pales compared to what we're experiencing now, of course, but the Pandemic Ethics Project talked to tribes, talked to rural communities, talked to people from North Minneapolis, just a good group of Minnesotans from every walk of life around the state, and came up with some principles that we would use, or that it suggested that the health department should have promote to health systems to use if we ever get to where we have to, for instance, ration ventilators. And one of the key issues, at least for me, and one that I have raised, and I want to stress that what I'm talking about now are not positions of the Minnesota Nurses Association, but they're discussions that I feel members should be aware of. But one of the issues that I have raised is about where frontline healthcare workers, nurses, physicians, respiratory therapists, paramedics, people who are really exposed to high risk of contagion, and in large part because of the failure to prepare for this pandemic adequately. So should those workers be given any prioritization when it comes to rationing? And the Pandemic Ethics Project from 2010 said that while key workers, these healthcare workers, should get prioritization to receive resources like vaccines when they get developed, or for other kind of treatments like that when they're developed, that they should be prioritized for that. They should not receive priority for allocation of ventilators when they become critically ill. And the reasoning for that was the instrumental value of healthcare workers makes it logical to give them vaccines, to put them at the top of the list for people who get vaccines, so that they can continue to carry out the vital duty of healthcare delivery. So it doesn't make sense that if you're already inadequately staffed, that you would reduce your ability to provide healthcare by not prioritizing your healthcare workers. But for things like ventilators, that prioritization was not recommended by the Minnesota Pandemic Ethics Project. And that was based on the idea of how would you make those decisions, and would you end up depriving too many people of ventilators? So there is, across the country now with this pandemic, there is a variety of ethical thinking about whether healthcare workers should be prioritized for critical resources like ventilators, or whether they should not. And an example is in New York, their ventilator allocation guidelines say that healthcare workers would not be prioritized, but in Michigan, they would prioritize healthcare workers. Here in Minnesota, now with the current discussions on what we do if we get to that unfortunate point where we're rationing ventilators, there is a division of thinking. There are people who agree with me that because of the involuntary forcing of increased risk on frontline healthcare workers due to the inadequate preparation for this pandemic, even when we knew it was coming. So because of insufficient PPE, essentially, that people were forced to work with, that if it comes to the point where ventilators need to be rationed, and there are healthcare workers who need those ventilators, at some point, those healthcare workers should be prioritized. Now, keep in mind that the very first triage decision has to do with clinical prognosis across the board. It's not going to be, and I wouldn't advocate that an emergency department nurse should get the first ventilator, or should be the first one to get a ventilator when they are being rationed, over and above someone who might do better with the ventilator. So clinical prognosis is always going to be the first decision, the first criteria in deciding who gets these kind of resources. And I don't know if any of the nurses in the audience are familiar with something called a SOFA score, Sequential Organ Failure Assessment. It's being discussed that SOFA scores, we talk about multi-system organ failure. So somebody whose SOFA score is very high because they have a lot of organ failure going on, combined with clinical judgment, those folks would not be good candidates for ventilators, whereas someone with lower organ failure and a better prognosis, someone who could get maximum benefit, would receive priority. At some point, the question is, So if you allocate ventilators and similar critical care supplies and beds to people based on their clinical prognosis, at some point you may get to having to make decisions about people who are candidates for ventilators, but they have equal prognosis. That in the judgment of the triage team, that there is enough equal prognosis for those folks that then you have to decide by chance, kind of by random selection, almost like a flip of the coin, who gets that life-saving treatment. And it's at that point where some of us feel the tiebreaker there should be the healthcare worker, that the nurse who's been forced to work with less than evidence-based PPE, or the respiratory therapist who's had to do perhaps maybe a lot of, excuse me, bag valve masking of patients or more exposure to aerosolizing procedures, that those people should get sort of like a tiebreaker status. And then there are people who disagree with me and disagree, feeling that it's too hard to ascertain healthcare workers, frontline healthcare workers, and that you get on a sort of a slippery slope of, so who does that include? I don't believe, and the folks who agree with me don't believe that just because something is hard to operationalize that you shouldn't try, and that the degree of injustice and lack of fairness because of the disregard for pandemic preparedness adds weight to providing that resource for the healthcare worker. So I want to bring this up because I feel that as nurses in their workplaces and as MNA in discussion with the governor's task force and with the healthcare commissioner, with the Minnesota Commissioner of Health, that these discussions should be happening, and it should be clear. Just communication's been stressed by the other speakers on this webinar, that it should be clear what the crisis standards of care and the rationing decisions, how they are going to impact frontline healthcare workers. So I think it's important for you to know that. Hopefully that we won't need this. So hopefully we will get enough of the equipment that we need, and we won't be having to ration. And my last comment is, as we emerge from this terrible crisis that we're all dealing with, we should make sure that there is, that we don't go back to this, that we never again have to deal with this kind of crisis that could have been much better mitigated. And that's an advocacy piece for all of us. And we also should not let crisis standards of care seep into a return to conventional standards of care. The issues about what kind of a mask is reusable or not reusable, what kind of staffing is acceptable or not acceptable. We should be very clear that what we do in a crisis should not become the new normal. And with that, I apologize again for not being able to have visual connection with you, but I hope this has been somewhat helpful.
Thank you so much, Eileen, for presenting. Once again, we're having a little technical difficulties getting our handout up and uploaded to this site. Hopefully we'll get it uploaded during the question and answer period. All of these references will be listed on that resource, that handout. So hold tight on that one. Go ahead, Rob, if you want to turn to the next slide. So I am really excited to have our next speaker presenting. We're going to be hearing from Brittany Livacari. She is a registered nurse and a chair at United. Go ahead, Brittany.
Hi, everyone. So I was asked to speak because of my past history and how I kind of started my nursing career. I am originally from New Orleans. I started my nursing career in 2005. I had just finished my new grad orientation, not quite a month before Hurricane Katrina hit. So it was kind of a trial by fire and jump right into it. I am so thankful for everything that I was able to learn. I was able to work with some amazing nurses. I had great mentors, and I don't know how I would have survived it without those mentors, to be totally honest. But we did have to face some of the really difficult ethical questions that were just talked about by the last presenter, and it's hard. It's hard weight to carry on your shoulders. What I learned that I would like to share with everyone here from Katrina is it weighs on you. No matter if it is difficult decisions of rationing ventilators and not being able to provide the type of care that we would have normally been able to care when it's not a crisis, to even what we're facing right now with just the fear of the unknown and how bad is this going to be? Are we going to be able to provide the care that we know our patients deserve? And it's just a really hard decision, or just it's hard to deal with. What I learned from all of this, and it took a while for me to kind of realize that this is what was going on with me, was when you're in the moment and you're in a crisis, we're nurses. We always jump to it. We jump right in. We do what's right. We give everything. But we tend to forget about ourselves. When you have to make those tough decisions, what are we going to do to help protect ourselves? And how are we going to be able to continue to provide the care that we know our patients deserve? It gets a lot harder when we don't care for ourselves. I learned that when I first moved up here. I moved to Minnesota about 5 years ago, and it wasn't until I was completely pulled out of living in New Orleans and still surrounded by the people who have gone through the same things as me and has lost our community, and things had changed so much. It wasn't until I was here 5 years ago, maybe about a year after being here in Minnesota, that I stopped and I realized, like, okay, I haven't dealt with this. I haven't dealt with the crisis and the tough decisions, ethical decisions that had to be made during the storm. And I realized, yeah, there's a reason why every August, September, I can't sleep at night, because the weight of those decisions had never been dealt with. We just push them away and we don't deal with them and we just keep going. And if I had to compare anything from what's going on with COVID-19 and the crisis that we're facing versus what happened with Katrina, and take a lesson from that and learn from it, the most important thing is to take care of yourself. Find the time to slow down, to pause, and take the moments to deal with some of the tough decisions. And I know that the peak isn't here on us yet in Minnesota, and hopefully we don't have to make some of those difficult decisions with rationing ventilators and rationing certain cares. But right now, we're still dealing with a lot of crisis. This isn't the world of nursing that we started with. And acknowledge that. Slow down and take care of yourself. If it's from those ethical decisions to the fear of the unknown, the loss of your community, like the things that you were doing outside of work when you were gathering with groups of friends, acknowledge that and acknowledge that that's difficult, and pause and find like ways to deal with that. It's difficult with right now, we're seeing ourselves kind of step into try to fill the gap for our patients with not having their families by their sides, and trying to not only be the best nurse that we can be for them, but we're also trying to provide the support that's maybe missing because their families can't be by their side. So it's just really important to take care of ourselves. Without doing that, if we can't take care of ourselves, we can't be the best nurse that we can be. We can't be the best person that we can be. It affects us, and it's extremely difficult and extremely important that we pause and take that time for ourselves. And that's all I have. I'm more than welcome. Like, I'll gladly speak to anything else about it, but I just wanted to like share some of that and make sure that, you know, we take care of ourselves a little bit.
Thank you so much, Brittany, for sharing your experience and what you saw and felt during Katrina. Go ahead if you want to, Rob, and turn to the next slide for us. Do we have Sarah Simons on the phone or on this webinar at this point?
Yes, I'm on the phone.
Oh, wonderful. Okay, so next up, we're going to give all of you some resources that are available for nurses during this pandemic. And our first speaker is one of my favorite all-time people. We have Sarah Simons. She is a registered nurse at HCMC. She's a chair there, and she's also the ethics committee chair. Go ahead, Sarah.
Hi, thank you for that introduction. I am coming to you today from my front porch. It's actually a beautiful sunny day, as many of you probably know, which we can all be grateful for. I really think that this is well timed in the order between what Eileen Weber had to say and what Brittany had to say about self-care, and how nurses tend to avoid or not have the skills necessarily always to do good self-care, and sometimes that can lead into issues with substance use and increased stress in this situation that we're all facing, and isolation. There are probably folks that were in recovery that have relapsed, or that have gone further down a path of substance use from a recreational level to something more problematic. And Nurse Peer Support Network is here to assist nurses that are currently in recovery or seeking to become a nurse in recovery. And we, of course, had to not continue with our in-person meetings. We have meetings around the metro for nurses in recovery and cooperate with HPSP through that. But in lieu of that, we have had good success with an online platform. I believe Christina has a slide for this. It's called In the Rooms. It's all one word. And there are meetings every Tuesday night from 7 o'clock. And what you do is you set up an account on that particular platform and look for Nurses Helping Nurses for the online support group that meets every Tuesday night. In addition to that, Nurse Peer Support Network also has a number of conveners who have made themselves available to speak one-to-one with nurses to support them during this time, and almost in a sponsor type relationship, not quite that formalized, but just somebody to reach out and touch in terms of recovery goals and support in the process. So that's available and it can be accessed through the Nurse Peer Support Network website that I believe Christina has also provided for you. So I think it behooves us all to do what we can to support one another, to practice good self-care, and by whatever means necessary to make sure that we are taking care of ourselves so that we can effectively and safely take care of the patients that are coming our way. That's really all I have. I'm really excited about asking and being a part of the question and answer portion later on this town hall, and I'm grateful to MNA for sponsoring this town hall type meeting. Very helpful. And that's it.
Thank you, Sarah. We can go ahead and switch to the next slide then. I want to be mindful that there's probably a lot of questions, so I did want to point out an additional resource that's available for nurses. The Minnesota Psychiatric Society, along with the Minnesota Psychological Association, Minnesota Black Psychologists Association, and Mental Health Minnesota, oofta, lots of words there, are offering 20-minute support services for frontline caregivers. This is a traumatic experience that we are all going through, whether or not you are frontlines working directly with COVID-19 patients, or whether or not you're like me and wondering if you have a job to go to anymore. This is a traumatic time period that we're going through, and we do need to be very, very mindful of taking care of ourselves at this point. So this is a resource that nurses, along with other healthcare workers, can call up and speak with someone about some of their concerns, some of the issues, some of the feelings that they're experiencing during this pandemic. So again, hopefully we'll get that handout listed for you, and this will be available for you in that handout. And we'll go to the last slide that we have. And in closing, before we get to questions, I did want to remind or tell all of you about an event that you can participate in tomorrow. I guess there is another protest that will be happening tomorrow, protesting the stay-at-home orders. It's going to be taking place in front of the governor's residence. We know as nurses the importance of staying home. And so if you'd like, there is a movement through Take Action. MNA is a co-host, and they are asking for people to take a selfie of themselves with a mask with their arms crossed and posting it to their website and using the hashtag MN Solidarity or Stay at Home Minnesota. So I encourage everyone to participate in that if you are able. And we'll go ahead to the last slide we have. And we are now to the point where we will hopefully be able to answer some of the questions. I'm going to turn it over to Jerry to facilitate this moment.
Okay, all right. Right now, I don't have an actual long list of questions yet. So folks, if you want to ask questions, if you look in the, there's a question section in that rectangle on the right side of your screen. And if you fill in a question there, we'll start dishing those out to our speakers. So. And I apologize if you can hear my dog barking. Well, if there are, oh, here we go. Well, that's not a question, but it's a very nice comment from Todd. I would like to thank the union for actually supporting us nurses in a manner the employers have failed at completely. We will accept nice comments too. You are the union, folks, so every single one of you is doing this work. So good job. Here's another question. This is from Andy. Will you send out the list of references so we can share with other nurses, in particular the Nurse Practice Act and ethics resources? Yes. We did just upload a handout. Hopefully you can see it now. It's uploaded as a PDF, so all the slides should be in there with the resources and links and everything. So please do get that. We will also send out a follow-up email to everyone who registered after the town hall, probably early next week, where we'll have links, we'll have the handouts, and we will have we'll have a link to a recording of this webinar that we will be posting on the MNA YouTube channel. So if you missed the first two webinars we've done, those are already posted on the MNA YouTube channel. It's very easy to find. You can literally just type Google Minnesota Nurses YouTube and it'll take you right there. Okay, so we have a few more questions coming in now. Yes.
Jerry, may I just jump in?
Please.
If you're calling in on your phone, if you're looking at your phone across the top screen, there's a little icon that looks like a piece of paper with the bottom edge folded up, and that's where the handouts are found if you're calling in on a phone and not on a computer.
Great, thank you. Let's see. So we have a question from a nurse asking, do our employers have to give us time off for mental health appointments while working? And I'm not sure if we have anybody from the labor department on the line right now. Is there anyone that wants to field that question? Okay, I'm gonna have to. I think you should check in your contract, because it might be different for each, but presumably you would have sick time earned in your contract that you could use for time off, and there's probably a policy within your own bargaining unit about arranging for time off. So that is probably something we can't answer specifically, not knowing your individual contract. Next question was, let's see. How is the information about what to do if you are asked to be a nurse extender going to get out to all nurses? So we can put together, we will send out all the slides, and then there will be a recording of this webinar. Jackie, do you have other resources that you want to share with nurses on that issue, specifically on nurse extenders?
I can see and certainly upload and send out. Jerry, would you just repeat the question one more time, just so that I'm sure that I heard it completely? Yep. Thank you.
This is from Julie, and she's asking, how is the information about what to do if you're asked to be a nurse extender going to get out to all nurses?
Okay, so what I have seen so far, and I think Carrie could agree, is that each hospital that we've worked with has sent out their own definition. For example, Health East has a chart that lists the duties of the nurse extender and the nurse helper, which does seem to be helpful. And I referred to that a little while ago, because the duties of the nurse, or the role of the nurse extender, it goes beyond what our definition of delegation is. I'm being confusing, I'm sorry. It's saying, because a lot of these staffing models say the ICU nurse delegates to the med-surg nurse, but then the med-surg nurses have their own patients, and they're also given the title of nurse extender. And nurse extender is more, according to the National Institutes of Medicine, a nursing assistant. So that's where it gets confusing. What would be really important is just to understand you are still a nurse no matter what title they give you, and to take care of the patient safely. And each hospital, in short, should provide for you a description of your roles, and what the definition is, and what the expectations are for you in that role. And if you haven't received it and you're being deployed as a nurse extender, then work with your labor rep to get those documents, so that you know what the expectations are and you're not practicing outside your scope, so it's very clear. And if you want any help with that, to look at it when you get those documents or they're not providing you the documents, please reach out to me and I can help you further with that.
Hey, thank you, Jackie. Let's see. This is a PPE question, which are very popular. Unfortunately, we're having lots of issues around PPEs. This is from Mary asking, we're being told that we need to reuse protective gowns and hang them up in patients' rooms and reuse them. What recourse do we have to not have to do this? Who would like to take a swing at that one?
This is Jackie. I'll take a swing at that one. We've had this discussion. It seems to coincide with the issue of nurses having to take scrubs home. And I just caught a glimpse yesterday in a labor management meeting. I caught a comment by an administrator about laundering and CMS and some requirements around that. So now I'm digging into this further. Why are we needing to reuse? What is the laundering issue? What I've learned is that there isn't, isolation precautions are the gowns that you throw away, and now they're using the regular gowns that you wear in your scrubs, which nurses do like to wear, but it's not generally part of isolation precautions that I've ever seen. And so this topic has just come up because it seems as though either certain hospitals have run out of the disposable gowns and now have gone to this new procedure where they're using the surgical gowns and then hanging them up. And so there's a lot of concern about taking off the gown and it's inside out, and then that becomes contaminated and they put it back on. And what was more as problematic as using the gown as part of isolation precautions was that nurse assignments are mixed. So that's another topic. And these COVID patients or rule out patients should all be on one assignment or in one area and not be mixed with non-COVID patients. So nurse should not be going into isolation, coming out, going into a patient room that's not either a rule out patient or a COVID positive patient. And if you have any questions about that, please ask me. So I guess to answer your question, I don't know the full answer to that, but I'm digging into it and I'm going to see if there's anything to do with CMS or any other regulations that are guiding the hospitals in their decision to do this and where we can push back, because I believe we know it's not safe practice, certainly not the best practice. So please keep in touch, and if you want to send me an email so that I have you on my list to get back to you whenever I learn anything, then I'd be happy to do that. Thank you for your question.
Okay, and this is Jerry, and I would just also add for people who are facing the issue of insufficient PPE or inappropriate PPE or not enough PPE, we have seen success in bargaining units when the nurses band together and demand something better from their managers. So it's not always a victory, but when people get together and demand it and say that I will not work in unsafe conditions, and everyone's in it together, we have seen some success with that. So I would definitely suggest working together with your colleagues, approach your manager, go up the chain of command if you need to, and then we'll be working on, as Jackie said, some of the kind of bigger regulatory issues around that to see if there are any, if there are regulatory issues. And I see Carrie just popped back in. Did you want to also address that, Carrie?
Yeah, not to, restate everything, but I think it is so critical and important to recognize that this issue in itself is so unjust that you are even having to that we are having to have this discussion, that you are having to fight every hour, every day, every shift that you go back. It's a disgrace. It is irresponsible on our healthcare systems, the facilities, et cetera, whether it be decisions they made related to lean management decisions, et cetera. And as Jackie pointed out, we know that every facility seems to be directing nurses to do something different. We can't seem to get clear answers. You know, the irony in a lot of this is that prior to COVID, some of you would have been probably pulled in for an investigatory meeting and or questioned or scolded about reusing PPE and, you know, hanging up a gown instead of putting it in the laundry, et cetera. So the practices they are expecting you to do now, just a couple months ago, would have been something that they would have, you know, either reprimanded you or had a discussion or a teaching moment with you, et cetera. So to think that now we're going to change and go back, change the way we used to do things simply because of lack of supplies, it's just incomprehensible. I think one thing, as Jerry mentioned, that we've seen success in nurses banding together and insist on having what they need in that moment. And to echo what Jackie always teaches every time that we have a class is you have to call up the chain of command. And we know that when nurses are meeting with managers in, you know, meetings during the day, they'll ask questions, they don't get answers, but we do know that it has a different impact when you call up that chain of command at 2 a.m. on a Saturday because you don't have the supplies, right? So letting them get away with having the discussion in a comfortable room online where they don't actually have to face you or be in the same room with you is an easy out for them. And I don't mean to make every manager the enemy, etc. So in that vein, reach out to your manager if you have a good relationship and find out what they need from you in order to advocate on your behalf, right? That sometimes we know that their hands are tied and or they can't advocate enough because they don't have examples, right? When we talk about that we need more nurses on a unit on a specific shift, we have to give examples of why. Is it the wrong skill? Is it the wrong you know, experience level, etc. So give them an opportunity. They may not be able to advocate to get what you need, but at least give them that first opportunity. It'll make you feel better that you attempted to work with them, etc. But we all know that your frontline manager probably isn't the one making decisions. And so we have to stress to go all the way up that chain of command and ask and demand for what you need, because when you protect yourself, you protect the patients in the community that your hospital is giving care to.
Thanks, Carrie. We have one more question. I'm not sure if we have the answer to this, but I'll throw it out just in case someone else knows this. When will the Minnesota Department of Health update the modeling data? It's still from April 10th. I haven't heard about that, but I have not been following the modeling very closely. Does anyone else know the answer to that?
Jerry, I don't know the answer, but I know it's not updated as frequently as people would like. And so we will try to find out, but you know, there's always another avenue, kind of like what Eileen said, that as nurses, our responsibility doesn't just rely inside the facility, it goes to the Capitol and all the way up to Congress. So go ahead, give your state legislator a call and find out if they can find out for you how often that information's updated. You're trying to plan, you're trying to help your facility plan for the surge. How often is the model updated? Is it reliable? All those kinds of questions, because with their title, they sometimes can get different answers and faster. So I suggest that that's one avenue, but we will also try to find out and then post that information with everything else that we're posting related to this webinar.
This is Eileen. Could I just add something to what Carrie said?
Please.
I think it's really important for frontline nurses to also contact folks at the health department. I can't remember if there's hotline there or not. Seems to me that there is, but whatever communication, maybe MNA can help clarify what the best communication would be with the health department. I know that MNA leaders meet with the governor's task force and the health commissioner, but this issue of PPE, I can't stress this enough, has changed everything. It has changed. I frankly don't think it's given enough attention, even though it's given a lot of attention. And I think that what the health department hears from system leaders and facility leaders, and I think they may get the word that there is enough PPE when in fact there may not be. And so I think or that these kind of fly-by-night make-do strategies are being improvised. And I just think I think Commissioner Malcolm needs to know what the reality is at the bedside, not just what she's hearing from healthcare leaders.
Thank you, Eileen. So that is, I believe that's it for the questions. I do want to encourage folks to go, oh, I'm sorry, wait, there is one more. Mary asked, where is OSHA in all of this? And Christina, I don't know if you would like to jump in on this question. They have been doing some investigations, and there have been some consequences, but I don't have specifics. Does anyone want to touch on that one?
I think someone would just wanted to say hi. I've been getting attacked the last 10 minutes. Oh my gosh. Can we, since it's at the end, I get to say OSHA's been sleeping, CDC's been sleeping, right? Like, I think they are going in and doing some investigations. I know they've been out at HCMC. What's happened with that, I haven't heard. So we'll keep looking into that. Maybe someone else has a better answer than, oh gosh, Anchovy, sorry.
Yes, so I do know that there are nurses that have been making OSHA reports, complaints to Minnesota OSHA. I'm not sure about in the other states where we represent members if they've had any luck, but we have heard some individual stories of nurses reaching out to OSHA. And so when we send out a follow-up email, we'll put in the phone number to call or the website to go to where you can file an OSHA complaint. Their process is not fast, so they have to send a letter, and then it takes time to do the investigation and so forth. So that is not going to be a quick fix to the problem, but we have seen them do some investigations and have some limited success. So we'll include the information about OSHA in that follow-up email. I got another question here from Patty that said, should we copy our union steward on our manager email? And I'm guessing that that's if you're reaching out to your manager about getting something that you need, is it PPE or a change to an assignment or something? And I think the answer is always yes, to keep your leaders in your hospital on the same page as you.
Jerry, it's Carrie, obviously. Absolutely. Jackie, Christina, and I, and Kathy McQuillan, the other educator in our department, would always encourage you, not like you want to do more documentation, but to keep a diary of who you talked to, what time you talked to them, and what their response was. So in the event that anything else comes up later, you have your own paper trail. So even if it's not directly copied on the first one, then forward it to them afterwards. But then please keep a very detailed description and diary of the request, how it was responded to, if it was responded to, just like on the Concern for Safe Staffing form. We want you to alert and hold management accountable. This is no different.
Thanks, Carrie. So the last thing I would just love to ask everyone to take a look at the MNA website when you have a chance. We have compiled a lot of frequently asked questions about COVID-19. And so there's a ton of information there, a lot of questions about PPE, a lot of questions about assignments, and we'll keep updating that. So every time we hear about a new issue that is coming up in a bargaining unit, we'll try to address that in the frequently asked questions. There's also some really important actions that you can take that are on our COVID-19 page. We have a pandemic Bill of Rights petition that we are asking nurses as well as members of the community to sign, which is demanding some safety assurances for frontline healthcare workers. And then there's also the COVID-19 incident reporting form, and that's a report that goes back to MNA that helps the staff and leaders keep on top of what are the different incidents that are happening in the bargaining units, and are there ways that those can be addressed. So I do want to encourage everyone to go look at that website, and then also National Nurses United's website has a tremendous amount of really good information as well. So if you have time to do a little reading, I highly recommend both of those. That's it for questions. I'll turn it back to Christina for any final comments.
Sorry, I was trying to get the dog off me, so working from home is a challenge. I just want to thank everyone for coming to this webinar and for the work that you're doing. I'm always proud to be a Minnesota nurse, but I am so extremely, extremely proud to be a nurse with you guys. You are amazing. You are rock stars, and I am forever grateful that I am in some way associated with you guys. So keep doing what you're doing, and please, please, please take care of yourselves right now. Thank you.
I would ditto what Christina just said, and please feel free to reach out at any time. I'm always happy to help resolve a problem that you may have, and thank you so much for attending the webinar today. It's really great to have an opportunity to talk to you about issues that you're having in your workplace and help try to resolve those issues. Best to you all.